as always, we very much appreciate your taking time out of your busy clinical and possibly surgical days to spend some additional time discussing this technology. So that's very much appreciated. Two real quick housekeeping issues. Please turn your phones on mute, and there's opportunities to develop questions, and we'll try to get to those. So as the presentation proceeds, if you have questions, you can go ahead and enter those real time during the presentation. Then we'll address them at the end of the presentation. So with that, we're very pleased to have an opportunity to present Tony Joseph, as our educational consultant, who will be discussing a topic that has not been discussed before, and that's a broader application of the Tenex technology based primarily on the TX2 MicroTip and primarily addressing deep tissue around the pelvis and some around the shoulder. And this is not a presentation that anybody has heard before, and it's being offered because of interest in what are the newer applications and the broader applications, and Tony's an expert on that. Tony's an assistant clinical professor of a family practice at Idaho State University, and he's the medical director for athletic training at that institution. Very accomplished. He has a lot of experience, and we're very pleased and privileged to have him as our presenter tonight. So with that, Tony, I'll turn it over to you.
Thank you, Dr. Morrey. I appreciate you asking me to do this, and I appreciate the listeners out there listening in on this subject. I come from a background of sports medicine, and especially sports medicine that started without much in the way of modalities, and through the years have developed the skill to use musculoskeletal ultrasound through multiple training sessions at the Mayo Clinic, and continue to teach at the American Medical Society of Sports Medicine. So a lot of us are interested in how do we approach tendons and how we approach them differently. I would start with something that happened to me. I was very frustrated at a point approximately 6 to 8 years ago, where I was trying multiple things for tendinopathy for my college athletes, but not really getting good results. And sitting at a meeting for the American Medical Society of Sports Medicine in San Diego, Jill Cook, who is a veterinarian that does a lot of work on equine tendinopathies, stated something to the fact that you can't PRP tendinopathy out of a tendon, you still have a degenerative tendon. And I started thinking back to Nerschel and his work on his biopsies on lateral epicondylosis and describing it differently. When I got back from the meeting, I looked into Tenex technology because we really got to think about how do we remove and restart this process, whether you want to call it degenerative tendinopathy, which is really the painful part of this, or tendinosis, which is the description of the tendon. We really have a failed healing response. When I'm looking at patients and I'm trying to get back to a normal tendon, I want to preserve a normal tendon, but I also want to make sure if I'm dealing with tendinopathy, is there enough tissue as an anchor to hold and act as a scaffolding for removal of the degenerative tendon. And I'm also thinking, I work with a group of surgeons, and we will discuss different cases, whether operative intervention would be a better option for certain patients with certain types of tendinopathy. I mean, even if you're minimally invasive and do it open or percutaneous with ultrasound guidance, the goal is to get rid of the failed healing or the tendinopathic process. A good point that a physician, Tom Durek in Oakland, brought up to me is that when I'm looking at these in the clinic, I will use lidocaine to inject within the tear or tendinopathy to get an idea of what the extent of this is, and I will look at this in orthogonal planes. So I'm always, if you will, scouting these tendinopathies ahead of time. I'm trying to get as much information as I can ahead of time. So I use my ultrasound skills to be both a diagnostician, but also to decide whether where we should go with this. The thing I like about the TX1 and TX2 is that it has a very small cutting path, and we can use the ultrasound to cut or remove the pathologic portion of the tendon and leave the rest alone. And that's the difference. It not only removes it, but it aspirates it as well. And it has several safety features that I don't need to go into, but it protects us against removing too much. And my point is too, if it's removing the degenerative tissue, is it what the key word we use in a lot of clinics, is it regenerative? And in my thinking, it is regenerative because we're trading this degenerative tendon that's full of necrotic tissue and getting it to regenerate back to normal collagen. And so it at least lessens this part of the disease. And so, you know, now that the TX2 is around, it allows us to go into deeper areas. Although my reps know that when I was dealing with adductor tendinopathy initially, I was using the TX1 and just using the TX1 down to basically the handpiece to try to get into the tendon. But now I have a lot more comfort zone, and it allows me to get into other areas a lot better, especially in my heavier patients that have gluteus medius tendinopathy, and also some shoulders. It also gives me leeway in how I approach areas, especially around the common hamstring origin, where I need that longer tip to avoid the sciatic nerve. And certainly what we're looking for, like this animal model, is return of the void that we create with the tenotomy that we do, a return to collagen that we hope is type 1 collagen, that is the majority of collagen in a normal tendon, but even type 3 collagen. And although these came back at 3 weeks in this rabbit model, a majority of what I see with my patients is a 6 to 12 week return to normal collagen. So we're really trying to stimulate that normal healing response. The thing, when we're talking about a clinical technique for treating tendinopathy using the Tenex system, I always like to confirm the lesion orthogonally, both in short and long axis. And we'll go through a little bit of this with my slides, but we in our clinic and our ambulatory surgery center and hospital, we will use a prep and drape, and we have specific drapes that we use that have an oval cut into them, because I like the oval shape of a cloth drape. It allows me to have a little bit more room to use my probe, and I can place it in an orthogonal position. We also use a sterile probe cover, sterile gel, sterile gloves, and we don't gown, but we use a mask and appropriate head wear. What we do before we start is we will place in a local anesthetic. The key with the local anesthetic, and I like to use either a combination of lidocaine and marcaine, but I also like to use ropivacaine as well for its safety features. And the key is that when I'm putting in my anesthetic, I like to do my injection of anesthetic in plane to the approach I'm going to take with the Tenex needle, and so get a sense of where I'm going. Again, we can use the technique from Dr. Durick, where we, this is usually another day that I'm doing it. I'm injecting into the defect. I will watch it blossom open and close and see where I need to be, because I want to be right in the middle of that. And I want to make sure I can get the device to go to the full extent of the pathologic tendon. And so I will inject down to the bone and then open that up. And then up in the right-hand corner of this slide is our safety scalpel. It's a number 11 blade. When you use a number 11 blade, and you can ask me about it, you want to make sure the cutting edge is away from your probe, lest you cut your probe, and I've done it twice now. And so you don't want to incise your probe, but you want to bring that blade down through the fascia. And so I like these safety scalpels, because the tip of that is almost the 2 inches that you need to go down with the TX2. And then most of us know how to probe back and forth. Treatment time can be variable, but I've spent up to 30 minutes on some harder and calcific lesions. So what I'd like to share with you is some of the different areas that I've worked on, and go through our techniques for this. The first one is the gluteus medius and minimus, and typically it's the gluteus medius. The thing that I always like to do when we're getting the patient set up is I like to think of the position of the tendon of the gluteus medius. And in this picture in the bottom right-hand corner, the gluteus medius attaches to two specific spots, the lateral facet of the greater trochanter and also the posterior superior facet. And it attaches near the back portion, and it is approximately 36 degrees off midline. And so when I'm lined up with my probe, I like my probe to be lined up in that 36 degree off midline approach. And then I'm also looking for the areas of pathology in the gluteus medius. And don't forget about the posterior superior attachment point, because a lot of times, especially in my very active patients, that can be the point of pathology, and you'll miss it if you don't go all the way superior and posterior. But occasionally too, I'll have pathology posterior and anterior, and I will use two separate incision sites. So that's another thing that I'll do. But I've also treated it pathology in the iliotibial band, the gluteus medius, and the gluteus minimus. Now this is a view that goes from this is anterior superior, anterior inferior to posterior superior, and this is pathology in a 67-year-old female that failed injections and physical therapy, and you can see this hypoechoic area in that region. And so once I'm in there, this is a view of the TX2 device within the pathologic tendon. You notice the hypoechoic appearance of the tendon, and I'm really moving the device through the hypoechoic area in the degenerative tendon and cleaning out or debriding that tendon in there as far proximally and distally as I can go. That was a long axis view of the tendon. This is a short axis view, and you can see the device going into that hypoechoic area of that posterior superior aspect of the tendon. And so we're cleaning that out as well. And so I will just sit at these open areas and clean that out. And the thing you need to know about these areas of deeper pathology, they're a lot of times a lot larger than you're used to in the elbow or even a jumper's knee. And so they require a little bit more time sitting in these areas and debriding this. So, and then once you're through, this is a long axis view. You can see these little micro calcifications within the tendon. You feel pretty good that you've hit that entire area. The other area of the pelvis that I do commonly is the proximal hamstring. I have a number of very active runners. I live in the Intermountain West, and so people will do trail running, marathon running. They're running 40 to 60 to 70 miles a week, but I see a lot of athletes with proximal hamstring tendinopathy. And the thing I'm going to bring up here is that just be cognizant of the sciatic nerve and the posterior cutaneous nerve, and remember that the semitendinosis and biceps femoris have a common origin here, but the semimembranosus goes up underneath and attaches more anterior lateral. And so I'm always thinking about, am I going to hit the correct areas of the tendon? I don't want to miss anything in there. For the purposes of this talk, I won't talk about the ischiofemoral attachment of the adductor magnus, but I have treated that as well. This is a 7-year-old female, and she had a year of pain, and she came to me in my clinic, and I also do some epidural steroids, and she was set up for an epidural steroid. Well, she came in and she goes, you know, I've had shots in my back, it doesn't work. My husband threw me out of the golf cart. He was trying to get their ball near the driving range, and he was afraid he was going to get hit. So he did an evasive maneuver, and she flew out of the golf cart and landed on her bottom. And here in this long axis to the tendon, we have a hypoechoic defect within the hamstring tendon here. And this is approximately 2 centimeters in length. Now this is in plane to the needle, but short axis to the tendon. It's a different view than that, but we have the TX2 device within the hypoechoic region of this tendon, and you can see some demarcations in the tendon, but the key is to get this device into the hypoechoic region of this. This SS over here was supposedly to mark the sciatic nerve, which is sitting down in this bottom corner. I'm very cognizant of that. But once we're done, then we see those micro bubbles that you typically see following a debridement with the Tenex device, and at least I feel good that I've covered that area, especially in this long axis view. That longer area, you can see all this here is micro bubbles, and so. And this patient, all these patients were patients that we did 3 weeks ago, so I don't have follow-up videos on those, but we look for neovascular changes at 6 to 8 weeks. It's controversial whether that matters, but I like to see vessels within the defect. And so we're looking for those to see if they've invaded within the area that typically was avascular. The third area of the pelvis is the adductor longus and gracilis, but in most cases, this is the adductor longus. And this is a source of pathology, mostly in soccer players. I see a number of patients. I run with a local general surgeon, a sports hernia clinic, and I get a number of referrals for sports hernias. These are not sports hernias. These are actual tendinopathic changes within the adductor longus, sometimes the brevis, and along with this, the tendon that comes medial to this is the gracilis, which is the only 2-joint muscle in the group. Well, how the gracilis has an interaction in this, I'm not sure, but I keep that in mind. But if you get an MRI that says this patient has a sports hernia because there's T2 signal change at the adductor longus, think about tendinopathy. Because in our definition, a sports hernia is a diastasis of the transversalis fascia. So we're looking at this. This is not pathologic tendon. This is our position for the adductor longus, and over here we have adductor longus, brevis, and magnus. This is inferior, this is superior. The thing I want you to see is that it has a continuous tendon with the rectus abdominis right here. This is the pubic tubercle. And you can get pathology anywhere from here up into here. So I have done tenotomy with Tenex on the rectus abdominis on a number of runners that get it there. Because the fibers come up, and unlike this primal anatomy view, the fibers actually of the longus and gracilis will cross over, and you will get a crossover appearance, and they also blend in with the rectus abdominis and part of the conjoined tendon. But this is a short axis view of the adductor longus. So this is pubic symphysis here. This is left-sided, like this diagram up here, and this is a hypoechoic defect into the tendon. This is, I wanted to show you this. This is the number 11 blade going into this defect in the tendon, and it's really hard to pick up the number 11 blade on the ultrasound, but I wanted to point out that we're bringing the 11 blade in there. And yes, I am very cognizant of where the spermatic cord or the round ligament and the genitofemoral branches, or at least the general branches of the genitofemoral nerve are before I'm doing that. This is a long axis view doing the Tenex within the tendon itself. So this is long axis to the tendon. This is adductor longus. This is a 40-year-old recreational soccer player. He plays 3 to 5 times a week. This is symphysis, and this is post, looking at the micro bubbles that form in there. As far as the shoulder, we have broadened our reach with the TX2 into pathology in the shoulder. And I work with a sports medicine trained orthopedic surgeon who has said to me, if it's calcific tendinopathy, unless it's rather large, I might as well do it because it's very difficult for him to see. So I do a number of calcific tendons, especially in the supraspinatus and infraspinatus tendon. But it also brings up a point whether we should be doing interstitial cup tears, whether they're partial tears on the articular or bursal side, and other approaches to the shoulder that I haven't done, biceps tendinopathy or the AC joint. This is a patient that we did several weeks ago, and I don't have a follow-up, but this is a calcific lesion within the supraspinatus tendon, and this debrided out very nicely using the TX2 device. And even with the thing I like about TX2, prior to using Tenex for removal of calcium deposits, we were using a needle lavage system, and I just find it's much easier to control, and I don't necessarily care if it's a type 1, 2, or 3, because it's a little bit more work to take out a type 1, but you can still remove it, at least in the shoulder, using the TX2. I find it removes it very nicely. The issue comes up with partial thickness and interstitial tears of the supraspinatus tendon. This is a long axis view of a 50-year-old type 1 diabetic with a articular-sided small tear. Even after 2 months of rehab, this patient still has pain and still has a similar looking defect. And the question is whether a Tenex tenotomy would be helpful for that. Sorry, I skipped ahead here. Because when you look at what you should you do an tenotomy with the ultrasound just using a needle, or should you use the Tenex device? The outcome is, in my experience, is better and is reported better with Tenex versus a percutaneous tenotomy, but it depends on which article you read. But there are a lot of people out there doing tenotomy with PRP, tenotomy with bone marrow and bone marrow aspirate, and then, of course, the surgical approaches to the area. So, which is probably all better than doing nothing. So, and with that, those are just some of my experiences with the TX2 device, and I wanted to have Dr. Morrey continue this, because I approached Dr. Morrey about the fact that I had some concerns about TX2 in the beginning because of some breakage issues, but with the modifications, I have not found that to be the case. So, Dr. Morrey.
Thank you. I guess I can't ask everybody can hear me, but really do make sure I have the audio control. First of all, that's a great presentation, and I know you hustled through it, even though there's a tremendous amount of material, and we have a lot of questions coming in, Tony. So we'll have a chance to explore and expand on some of the issues that you brought up. But I think it clearly shows a very high level of anatomic and pathologic understanding, as well as a technical expertise, and I really commend you on that. One of our goals of the topic and the presentation tonight was to highlight the TX2, and that instrument, which you see on the slide here, was brought out precisely for the reasons that Tony's been talking about, is to reach the deep tissues, and we didn't say much about it, but they're dense tissues. When you embed the probe in the origin of those tendons, there's not a lot of wiggle room like there may be for an epicondylitis. And so, as a result, in spite of the fact that our lab testing for the TX1 demonstrated that it had extreme tolerances to handle the amount of stress that it would be exposed to, so as so often happens in the clinical realm, we were seeing a highly unacceptable rate of fracture of the probe. And just so you know, some of those on the webinar tonight probably experienced that the sinister part about it is you can pull the sleeve out and the probe would still be left deep in the wound, and in one or two instances it may not have been recognized, or if it's recognized, it's not sticking out through the skin, so there's an additional effort to treat it. So it was in fact a major issue. We recognized it relatively early, within 3 or 4 or 5 months, and we posited a number of potential solutions, and I won't bore you with that, but we worked on it diligently for over a year. And fortunately, we finally did come up with the solution, which was a combination of 3 things. What you see on the slide right now is a design change, and all you really need to know is you see the old tapering of the device at the probe insertion into the component that is connected to the crystalline feature of the handpiece. And on the right, like as you might expect, it's more truncated, trumpeted, if you will, elongated, and in a way it has less of a stress riser type of effect. So that was a design change that we think had an impact. We did a number of things simultaneously, so we can't quantitate what percentage each of these had. Can we go to the next slide, please, Tony? So the physics of the problem was very interesting. It showed that as we made the probe longer, we got into a significant and somewhat unanticipated transverse or side-to-side vibration mode. And so the strain that was being applied to the probe as it inserts into the handpiece was extreme. And it was extreme enough to exceed the material properties of the probe. And so this was playing into the failure mode. So there are ways to adjust the manufacturing to dampen the side-to-side amplitude, and that was done. The third thing, which was very serendipitous to be honest, is we found that in the course of all the investigations we were doing, even though we had the same specs to our suppliers, there was a supplier that provided a needle that seem not to break as much. And this is before we put the last two comments I made into effect, the design change and the side-to-side manufacturing process change. And we found probably a 50% reduction in ruptures or fractures, rather, by just going to a different vendor. And that had to do with the carbon content of the stainless steel. They both satisfied the design criteria, or the specs of the manufacturing specs, but they were actually different in fact. So for your information, the simplest thing to understand for the reps that are on the phone and also for the clinicians is we made three changes. We made them pretty much simultaneously, not exactly, but pretty much. And our failure rate has dropped to about 0.3%. The TX1 is about 1/10 of 1%. When we were at the heyday of these things fracturing, it was at least 2%. So we have significantly reduced the failure. And as Tony was telling me earlier today, even when he's in deep tissue, he feels comfortable treating the deeper tissue with the new probe because he feels there's less likelihood of fracture, and that, in fact, is being borne out by the data. So after this, I think, excellent presentation on the applications of the longer probe at the shoulder and around the pelvis, we wanted to close by indicating that the probe that you are receiving is the current TX2 is the improved probe that has these design and manufacturing changes, which should provide the same level of confidence, or essentially the same level of confidence as TX1. One thing I mentioned, all the communications from the company that talked about treating in line and not going side to side still hold. Don't challenge this to see if you can break it. Still use good technique, and I think the chances of you having a fracture of the probe, certainly one that has to be retrieved, etc., will be dramatically reduced, hopefully approaching zero as a limit.
With that, we have questions and answers, and I think Dr. Morrey's going to address that.
Sure. Well, I'll read the question, and then you do the answer. So what do you say to surgeons in your group that might say you have a high risk of rupturing or tearing the tendon or fascia you're working on? In other words, they're questioning the safety feature of the device or technology.
In most of these cases, I'm seeing less than 50% of the tendon being pathologic, and the normal tendon, in my experience, and so far, I've not had any go on to full rupture. And I think the conduit or the scaffolding of normal tissue is a great safety feature. It helps me.
Yeah. If I could add just a little bit, I fooled around in the lab with the probe trying to cut normal tendon, and it's really bad. It just doesn't do it very well. And what was explained to me by the engineers when I first started is that the harmonic resonance associated with the ultrasound device is effective against certain material properties of soft tissue. And those material properties are degenerative tissue. So it's very effective in disrupting soft tissue that has certain material properties. When you start getting to a more formal or more organized or more structurally sound material, it's not effective, and that's a normal tendon. So I have tried to cut through normal tissue with the probe, and for your information, taking the probe in my hand, cutting and exposing an Achilles tendon, putting my finger underneath it, and then assiduously trying to cut the tendon with the Tenex probe. It took over 10 minutes, just direct visualization trying to cut the tendon. So the fact is, it is just not effective against tissue that has integrity in terms of its material properties. And so that's the key. And so in addition, the other safety factors are you're visualizing what you're doing. So when you're in a normal tendon, you don't cut it. You cut the degenerative tissue. And the actual energy that's emitted from the tip, that the tip actually sees, or the tissue sees, is a fraction of a millimeter. The rest of the energy is dispersed with a propagating wave of probably nitrogen bubbles is the theory. And then finally, the device shuts off if the irrigation stops or if the suction stops. So there's some hardwire safety features. There's some physics that appears to be a safety factor. And then just the visualization and the technique all seem to be safety factors. So Tony, the next technical question is, when placing the needle for a proximal hamstring tenotomy, where exactly do you make the incision site?
I am going lateral to medial, and I'm short axis to the tendon, but I'm in plane to my needle. And the nice thing about the proximal hamstring is the gluteal folds there, and you can, in a lot of patients, take the gluteus maximus and move it up just a little bit. Sometimes we'll tape it up and move it up. So we have very little tissue, very little fat there. And so I'll go lateral to medial, again, making sure I see the sciatic nerve and the posterior cutaneous nerve, and make my incision in about a 45-degree angle underneath the probe, trying not to cut my probe again, and then incising down to the middle. I try to hit the middle of that proximal hamstring. And if you look at the proximal hamstring, it doesn't come off, it comes off posterior and then slides lateral anterior off that ischial tuberosity. So it's nice, you can get on that sidewall of the ischial tuberosity and start working through that. The thing I would caution you, though, if you have some pathologic tendon tissue like that woman that I showed you, it extends out almost down to 2 to 4 centimeters. Almost in some cases, you have to work your way down through that pathologic tendon. So don't start too high on the tendon.
So one of the things that wasn't said in that description, which I think is really important, is if anybody attended the session that I had last month, I made the point that you did not have to be an ultrasonographer to use the Tenex, and that's absolutely true in 90% of the applications, which are epicondylitis, medial or lateral, jumper's knee, substance Achilles, Achilles insertion, plantar fasciitis, probably gluteus. But why? Because it's skin, bone, and tendon. And it's easy to identify the pathology, and it's relatively easy to challenge, but it's still not too hard, is to find the probe and then put the probe in the pathology. So you're doing it under direct vision. The things that Tony presented tonight is one step beyond. For what he's talking about, when you do have neurovascular structures relatively close by, you do have to have a higher confidence and a higher level of expertise with regard to ultrasound. And so that, to me, is my word of caution, is that Tony has had excellent experience and results in this area, and it's kind of a bridge beyond what most people were doing before he started doing it. Others are doing it, but they have similar training. So if you're going to go into some of these more difficult areas, what I have been doing is using an ultrasound radiologist to find the pathology, and then I treat it with the Tenex. But the alternative is you must know the anatomy yourself and to maintain the safety profile. Kind of along the same lines, do you position the patient? How do you position the patient when you're doing a calcific rotator cuff procedure? Same lines as a technical point, I mean.
So we've found that if we position the patient in a beach chair position with their arm hanging, and we will approach that from lateral to medial. The OR staff is really good about placing them in a beach chair position, but we also will place their arm behind them. It's a modification of the CRAS position for looking at the supraspinatus. So the arm is just sort of gently sitting behind them. And I apologize, I didn't have slides looking at positioning, but that brings out the supraspinatus from under the acromion and allows us to approach it from lateral to medial in plane to the probe. It depends on the way that the calcific deposit sits. If it's wider than it is long, sometimes I will approach it from anterior to posterior so that I can get through a majority of the calcific deposit.
I think the key point is, in general, most people that are doing this place the hand behind the back or on the buttock. It's an internal rotation maneuver that brings the supraspinatus in view and underneath emerges from the acromion. That's where you can most readily identify the calcific deposit usually. And usually, well, not usually, when you're doing the calcific deposit, it's wise to both use a long and a short axis view to make sure you get it all. And when we say get it all, we don't know exactly what that means. By that I mean that sometimes you can just fragment. It depends on the stage that it's in, as Tony pointed out in one of the slides. But if it's stage one, where it's really mature and circumscribed and dense, it's much more difficult than when it's stage three, where it's more pasty. And sometimes if you just fragment it and make a whole lot of small pieces, of course the Tenex probe sucks it out. But if you don't get it all and you still see a few flecks on X-ray, next time you X-ray it, usually those flecks are gone, because once you break it up, the body will tend to resorb the residual. There's a question in what is the timeline for RTP after a procedure?
Say that again, Bernie.
I'm sorry, what return to practice after?
Oh.
I guess it says a procedure. It doesn't say which, so you may distinguish a shoulder versus a pelvis. But what is the usual time frame to return to practice?
So we looked at it, and I didn't present some of our graphics from adductors. Our adductors, on average, in a college and high school athlete, will return to practice at about 4 weeks and play at about 5 weeks. But it's definitely longer for a proximal hamstring because of the eccentric demands on the hamstring. It typically can vary anywhere from 6 to 8, but sometimes 12 weeks. It can be a lot longer for the hamstring as far as that goes. I haven't done any throwing athletes with the rotator cuff, so I can't answer that question.
I think in general, we have kind of a curve that we show that probably 80% of the patients that are going to respond will respond by the second to third month. And it depends on the tendon. If you're dealing with the patella tendon, you got to be really careful about returning them to very high level, because a football player or a basketball player that's jumping or firing out from the line of scrimmage, the last thing in the world you want is a ruptured tendon. And to remind the people that are on the call, 75,000 plus cases, 3 ruptured tendons. So we don't want any of them. So I go very slow on a patella tendon. I try not to have them return to full activity for at least 4 months. The others are pretty much activity is tolerated, and it varies a little bit by anatomic site, but it's very similar to what Tony just said in my experience also. In regards to the deeper tendons and body habitus, obesity, etc., are you limited in the length of the probe? In essence, are some patients just not good candidates because they're just too thick, or they're just due to this issue?
Yes. So when I'm looking, especially at the gluteus medius, when we're doing our office evaluation and our diagnostic ultrasound, I'm looking at the depth gauge over on the screen and deciding, if it's beyond the TX2, because if I'm getting up to 4 centimeters, 4 to 5 centimeters, I'm probably going to say no. But you can. There's a little wiggle room in that the skin incision could be made a little bit bigger, And again, you can use the neck of the device, although not putting torque on it, but use the neck of the device to give you that extra half an inch to an inch. So I will go a little bit longer than the 2-inch on the screen.
To expand on that, this is a legitimate question, particularly for me in the gluteus area, where if somebody's a little on the thick side, that's the one lesion that I am concerned about. And I've done exactly what you've done, made the incision bigger and actually embed my handpiece through the skin and then push to get to the origin of the problem. How frequently have you ever had a case where you did everything you could and you still didn't feel like you quite reached the pathology?
No, I think in combination with what you said, bringing the neck of the handpiece down and using my other hand to push down between my thumb and index finger, I've been able to accomplish that. But those are only patients I felt comfortable when I saw them in clinic and measured the depth of it.
Yeah. I had a patient I made a mistake on. She was a nurse anesthetist, and she was really bothered by this. It was horrible. And I didn't know she was quite as big as she was until I got her on the table, and I thought, oh, my God. And I did everything we've said, and my tip didn't quite reach the bone. And I always like to tap the bone and try to get the bone to bleed as part of my procedure for all the anatomic parts. And I couldn't quite reach that, and I thought, well, I made a mistake. This and is not going to work out. She's probably my best result to date. So sometimes you just kind of get lucky, I guess. There's a question about, I heard that there is a new Tenex probe for calcific tissue. It may have a higher frequency. Have you heard of this? Or do we just have TX1 and TX2? Hey, Tony, if you don't mind, I'll take this. We have been developing a new probe, and the probe has been specifically designed to remove, quote, hard tissue, which of course is calcific tendinitis of the shoulder. It's Hageland's deformity at the calcaneus. It's the spur of the plantar fascia attachment. And each of you who are on the call may have an opinion about whether or not you need to take this down. I typically don't think you need to take all the calcium out or even address it. Sometimes it's really a tendinopathy. But if you feel like you have to, with this new probe was specifically designed to remove hard tissue. It was approved by the FDA about a month ago. And the company is in the process of doing something called an LUR, limited use release, and we are evaluating its efficacy and its use in the field. We hope to have this completed by the end of this quarter, and it will be open and available for general release by January 1 is our plan. To date, I will just say one thing. The engineers were given the charge to develop this probe to remove hard tissue, and it is incredibly effective at doing this. So the one area that we are emphasizing with these people who are trying it is get somewhat familiar with it before you treat a patient if possible, like in a cadaver lab, because if you're used to a TX2 removing bone, which we'll do over a long period of time, this removes it 6 times faster as the quantitative measurement, volumetric measurement that was made in the lab. So yes, we do have a new probe coming out. It's a little bit shorter, so it may be a little bit more difficult to reach deep tissues, but it's very, very good against calcific tissues. We also had a question regarding coding or reimbursement. I suspect others on the call may have had that issue. My colleague John Holder is responding to this person directly. He's from Colorado, or she, it's a he, is from Colorado. The reimbursement issue varies from the different parts of the country. Some areas have a lot of trouble with it. Some areas have hardly heard of it. That is being denied payment because they don't accept the coding. As it is right now, the most important thing that I can tell you with regard to coding is that if your coders are following the AMA's guidelines, and the AMA says this just does not seem like a tenotomy because you're not completely cutting through a tendon. Our argument has been you don't have to completely cut through the tendon, just remove, do whatever the pathology indicates. And I think Tony did a nice job saying what's indicated is cutting out the degenerative tendon. AMA has not accepted that. But here's the point. There is no legal obligation for your coders to follow the AMA. If you've got a rationale of why you are coding it this way and based on the findings of the patient. So it would be like, why would you completely cut through a tendon when only half the tendon is diseased? And that's kind of what we're talking about. So if you have other questions regarding coding or reimbursement, you can contact the company, and they will refer you on either to John Holder or myself, or feel free to contact me myself if or me if you like. Let's see if anything else came in. Are there hoops to jump through in order to be reimbursed? Does a patient have to fail several other treatments or have a pathology plan for certain amounts of time before the Tenex treatment is covered? No. We have characterized the treatment of Tenex to be for chronic refractory disease. I think it's wise to document that the patient is at least 3 months following onset, and during this time they have done something to cure this or to treat it, the very least of which would be activity modifications and maybe eccentric exercises. I'm talking about the general tendinopathy population now. But there are no proscribed rules of exclusion for this treatment, meaning that you have to fail a cortisone injection, you have to fail this, have to fail that. You should document that in your judgment this is a chronic refractory case and that the patient is desirous of a definitive treatment. And those are the keys. And then you should be you're on very firm ground to offer a definitive treatment. Emphasize the phrase that I use is the major factor that limits the patient's day-to-day activities, and it is not responding to treatments up to this point. If you say that, you can proceed with this treatment. Let's see, I think that's it. And we're, 4 minutes early. I really appreciate that. I was a little concerned because this is a new area, and I hope you appreciate the time that Tony took to prepare those slides and the graphics. Very well done, as well as the video clips. So, Tony, thanks very much. And being no other questions, I think we'll call it an evening. Thanks for your time. Very much appreciated. If you have additional questions, don't hesitate to contact me directly or Tony directly or anybody else that you think can help you. Thanks, and have a nice evening.